Welcome to the Back in Action podcast, where you're going to hear from me, a spine physician, Dr. John Lavelle, and two coaches, Dusty Holden and Josh Bunch. We're going to help you rethink pain, rebuild strength, and regain function so you can get back to enjoying the things you love in life without limits.
Welcome to Back in Action. Josh here with Dr. John Lavelle. Welcome, sir.
Have a good day.
It's great to see you. We're absent one of our humans once again. Coach Dusty is out.
Second week in a row. We're missing him.
Yeah, it's been interesting, but you and I tend to get right to the meat of it.
We'll get it. Hopefully, Dusty's gym is doing all right. He had that little fire, but
yeah. So Armor had a little experience. I believe it was a sauna.
I think so. That's what it looked like.
So
electrical fire, probably.
There's a lot of benefits to the sauna. That's not one of them.
You want to be hot, but you don't want to be on fire.
That's right. When the saunas go wrong, that's right. So last time we talked about injury specific to how we would recover after some sort of diagnosis that was true. In previous podcasts, we've talked about things that there was maybe nothing going on in terms of imaging. This was, there was something. Mm-hmm. There was something to deal with. We talked about how to recover. So if you didn't get to see our last podcast all on recovery concerning specific injury, then give that a listen. Today, we're going to talk about arthritis specifically, all things arthritis. We're going to try to define what people can look towards if they're diagnosed with that, what it means, what flare-ups are. I got a lot of content because, to be honest,
we could go on for hours on this.
We could, and arthritis to me, my original, I'm sure I'm not the only one, but I remember when I was 7 years old, cracking my knuckles. And I remember my aunt, and I still remember this today, she's like, terrified me.
Yeah.
Like, you're gonna get arthritis because you crack your knuckles. And I was like, oh, okay. And it was like a mythological danger that she had. And then for the rest of my life, for that appeal to authority for 20 some years, every time I crack my knuckles, I'm like, oh.
Well, the good thing is it's pretty much a myth. You're fine to crack it.
Okay, well that's
what
good.
Chiropractors,
We debunked.
Osteopathic physicians, they're always cracking and popping, obviously with a lot more specificity.
Debunked.
But it's debunked.
Okay, well that's good. I like that. So tell me a little bit, what is arthritis specifically, and then what are the different terms? So I've heard terms, and we've dealt with terms of rheumatoid arthritis, osteo. Like, walk me through all the things.
So arthritis it's universal. We're all going to get arthritis.
Okay.
So what does that mean? So arthritis, when you just say the word arthritis, there's a bunch underneath that. But most people, when they talk about arthritis, or when I would laugh because when I moved to Tennessee from Boston, everyone say, "Oh, I'm all eat up with Arthur," and I'm like, "Who the hell is Arthur?" But they meant arthritis, so that's the nickname. I thought that was pretty funny.
This is like my sugar.
Yeah,
like,
my sugar's a high. My sugars.
Yeah. Okay, got it. Okay, Arthur, that's great.
But so arthritis, most people that have arthritis, it's osteoarthritis. So arthritis within the bone itself, and the main driver to that is age-related.
But arthritis is always bone.
No.
Okay.
So osteoarthritis is that age-related degeneration that we all get over time. And we'll go into why. But then there's another part of arthritis that's more autoimmune driven. So another big one that most people hear of is rheumatoid arthritis. Mm-hmm. That's when your body, from whether it's a stress, an infection, we don't always know the cause of why we get rheumatoid arthritis. Sometimes it's genetic based on our genetic disposition from our family lineage. But rheumatoid arthritis is when our own body, our own immune system, starts to attack the cells within the joint. So it's joint injury, but not because of age-related breakdown. It's from our own immune system seeing cells, the cartilage cells in our joints, as foreign or bad. So it's an autoimmune response where our own immune system attacks the joint, basically.
And that's in a wealth of other autoimmunes that we can
So that's
talk about.
rheumatoid arthritis. There's psoriatic arthritis, which is similar. There's lupus arthritis. All of those are under that umbrella of autoimmune arthritic change.
How old can I be so you were talking about the osteo, is the osteo always age-related?
So it is progressive with age.
What about rheumatoid? Could I get that at 10?
You can see it. So there's juvenile idiopathic arthritis, which is autoimmune. Yes, you could see rheumatoid early on, but usually if you're kind of 18 or below, it's diagnosed as juvenile idiopathic arthritis. But yes, you can see rheumatoid arthritis in the younger age. Usually we get that kind of middle-aged and onward.
Okay.
But sometimes younger.
So it could be, though, it could be on the younger side. And
absolutely.
Then does the juvenile go away?
Sometimes it does. So we don't, again, it's called JIA, juvenile idiopathic arthritis. The idiopathic means we're just a bunch of idiots and don't know what's causing it.
Okay.
It's a great medical term. But it just means unknown. We don't always know why that's caused. If everything looks good, but we see on imaging that they have some arthritic change, it's this JIA, juvenile idiopathic arthritis.
Is this this is off topic, but would you see something like that, and then would you ever sub that out and be like, oh, I think this could be something else?
100%. Okay. So there's a Still's disease, and it can come with fevers and other things that can be causing it, or other symptoms with juvenile arthritis. So I'll almost always, if there's something like that going on with a person, whether it's rheumatoid or not, I always get rheumatology on board just to see, get a good full blood work up, see what's going on, and then make sure we're on the right treatment path. Because sometimes you need other medications to tone down the immune system based on the severity of it.
So let's say that I'm somebody who's having indiscriminate joint pain. Like, what does it feel like? Can you explain that?
It can be, I'd say let's kind of stick with osteoarthritis or age-related degenerative
Is that
change.
The most common?
That's by far the most common. And
it.
That's what I said we're all going to get as we get older.
Okay.
So I think for this episode of the podcast, we'll kind of stick with the osteoarthritis.
Copy that.
So what does it feel like? Your joints are achy, sore. You may get sharp pain. It can be a whole host of things depending on where you are in the severity of that arthritis. But if we take someone that I'll see a lot, 55-year-old gentleman comes in, little overweight, sedentary, back hurts, just right across the waistline. I'm almost
that
always
band.
my exactly right along that belt line. Immediately, the first thing in my mind is this is probably just arthritis in the joints of the back called the facet joints.
Okay.
We can use the facet joints as an example, but it's the same process for any joint you have in your body. What happens is our joints are two bones where they come together, but in between the bones are a layer of cartilage called articular cartilage, and in between that there's a little bit of fluid called synovial fluid, which kind of cushions the joint in there as well as the cartilage. But as we get older, our cells just start to die off in all of our body, whether it's our hair, our skin, or in this case our joints, and it's a process called apoptosis. It's age-related cell death. And so as those articular cartilage, which lines the inside of the joint, starts to break down, the chondrocytes in there as we get older don't function as well. And those chondrocytes are cells that build up the cartilage, but as those chondrocytes don't work as well, or some of them start to die off, we get wearing away of that cartilage and the body can't repair it.
So it truly is like a wearing down.
It is, absolutely.
So is this where, if you take somebody who's compression intolerant, you give me an athlete, like how we get shorter.
Yeah.
We've compressed that down. This is like the, if I'm thinking of distraction in terms of applying a band to a joint to distract the joint, to distract the synovial joint to get more fluid so that it moves with less friction, and then I feel better. Is that the same sort of premise why that feels good? Because all of you got less room to move?
And that's a traction. Chiropractors use, other clinician is put them in traction because you're gapping that.
And that's
so
also
it gives
like a
them
decompression.
some symptomatic relief.
Okay.
Unfortunately, most of the time we're going to stand up again and gravity takes over. So, and you haven't repaired that cartilage, so it's still there.
It's just a temporary relief.
And unfortunately, as we get older, the body doesn't have the ability to build up that cartilage anymore. So, but it can still put down new bone. So then you start to get what people call bone spurs, and that's where you can get kind of bone rubbing on bone, and that's what can become inflamed, cause inflammation in the joint, so you can get more fluid in the joint, in that synovial fluid, can expand, and it's a contained space. So if that fluid expands, or you get more inflammation in there causing edema or fluid buildup, then that becomes more painful because you're feeling that increased pressure in a joint that's going to get more and more
that's
irritated.
Also an impingement, and then it creates another wealth of issues that are movement related.
Exactly.
So you told me about how it felt. I'm constantly sore in the joints. It's probably worse in the morning.
So yeah, that's that typical. You go down at night, you can sleep. Sometimes it's even hard to sleep just twisting and turning, whatever joint it is, but we'll stick with the low back for now. First thing in the morning, there's theories to why first thing in the morning it's worse, probably because all of our muscles and ligaments kind of stiffen up, so it's putting more compression on that joint.
Pain tolerance is also lower in the morning?
Exactly.
Yep. Okay.
Also, there's theories that when we're laying flat in bed, our fluid in our body goes back to its normal positioning. So that would be the synovial fluid. You might have a buildup of synovial fluid in the joint. So again, it's increased pressure in that joint. So when you stand up, it's hard to kind of stand up straight. People say it takes me a good half hour when I get out of bed just to get up straight. I have to get in a hot shower, move around a little, but then I can start walking and get
this is and totally correct me, but I mean, when we sleep, our spine hydrates. So that's why When I wake up in the morning and my kidney kind of starts to shut down, so I don't have to go to the bathroom all night long. But in terms of the spine hydrating, that's why when I get up and I do this thing, it feels so much different than how I went to bed, no matter what I have done, right?
That's what I mean. So that fluid's kind of hydrating or going into that joint. Yeah. So it's that increased pressure in there.
This is where it's beneficial that upon awakening, maybe a warm shower starts to kind of kick that into gear, but also drinking water, so I expel water.
Exactly.
Okay.
So you turn those kidneys on, they start excreting some of that water.
And why you feel so much looser's not the right word, but I feel a lot less tension an hour later after I've had a big hit of water right in the morning.
I think it's the water and the movement.
Okay, got it. Now, can I see arthritis on imaging?
Absolutely, and that's kind of the mainstay. So if that gentleman, 50-year-old, little overweight, sedentary, that back pain worse in the morning, comes into me, I'll examine them obviously, but then also get an x-ray. And you can see that arthritic change in the joint. What does it look like on an x-ray? It almost looks hazy. So because there's increased bone formation there, because as I said, the body can lay down new bone to try and protect that joint. Because when you get that loss of cartilage in that joint, you get kind of some inflammation or irritation, so the body will it will put down new bone, so you can get little bony spurs, and that can cause some irritation in there, and that's what you'll see on that x-ray.
So on the x-ray, you see a haze, or you see the extra bone, or you see both?
It can be both, depending on the severity. If it's earlier, it'll just look hazier, because you're seeing the body's laid down a little new bone.
Okay.
But you may not have a big spur or anything like that. You'll also see the joint, instead of being a nice straight line that you would see in a nice joint, facet joint, where you can almost see the space in between the two bones, it'll look all ragged, the joint line, because the cartilage has broken down and it starts to irritate the bone in there and change shape.
A couple podcasts ago, we talked about MRIs.
Yeah.
Is that valuable in this diagnosis, or is it more towards an x-ray in this case?
Honestly, it's not really necessary.
Okay.
But it'll show you more detail. You can see the cartilage that's worn away, where you only see the bony structure on the x-ray. But on an MRI, you would just get more detail. You could see if there's increased fluid in the joint. So more inflammation has caused increased fluid or synovial fluid or edema in that joint.
Okay.
So it'll give you more detail, but it's not usually
you can do it
unnecessary.
without it. Okay. Now, so I'm that person. I've been in and you've diagnosed me. I have arthritis. What now?
So
what am I looking forward to if we're talking about
I'm going to step back with that case, but so why does that, what causes that in that person? Why did they start to get that arthritic change? One, I said it's the most common thing is it's age related. So everyone is going to get it at some point. But what else plays a role? So two, being sedentary.
Inactivity.
So you lose that muscle mass, which we've talked about, I think, every podcast episode so far. Those muscles in the back, or if it's in your shoulder or knees, those are so important to support the spine. So if you lose that structure that's supporting the spine, those in the back work like muscles holding up the spine. So if you lose that muscle that holding the spine up like a cable holding up a telephone pole, then you get more pressure on the pole, or in this case, the spine. So you're going to get more wear and tear there.
Got it.
So part of it's, loss of muscle mass. And where do we see that too? If you have some muscle mass loss with aging, then you also, and you're a little overweight, like our patient I presented initially, then that's going to put more stress. So you got more of that compaction, like I said, or you said, on the spine. So that's going to wear it out more. So you got age contributing, you can have obesity contributing, inactivity or loss of muscle contributing. But then mechanical stress too. So maybe the patient wasn't overweight. Maybe it's an 18-year-old high-level baseball player, but he's only been playing baseball since he's 10, 90 games a year, and it's his shoulder hurting. You can start to get some arthritic change in the joint just from that constant repetitive throwing motion. So overuse.
Got
so that also contributes. And last thing a lot of people don't talk about is we see it a lot in middle-aged women with hormonal changes.
So premenopause and so forth.
Yeah, so premenopause. So as you get hormonal changes, specifically you can see it in a lot in estrogen. Estrogen helps. The more estrogen you have, it increases, can help with chondrocyte, those cells that maintain the cartilage function. So if you're decreasing your estrogen, you're going to have less cartilage repair, and you get wear and tear more quickly in that articular cartilage. Same with low estrogen, you're going to have increased inflammation.
And then estrogen helps us actually have contractile potential of the muscle.
Exactly.
So as we get older, or when a female specifically gets premenopausal, they start to lose that ability to get power output.
Right.
And then we know that with the lost ability of power output usually lends to less jumping, but we also know that at least studies seem to point to jumping as a way to increase bone density.
Absolutely.
Jumping and weightlifting.
And we always blame estrogen, but women have plenty of testosterone too, so that's going to play a role in their muscle function as well.
But that's why it's so important, and then for females specifically, to make sure in a relative nature they're lifting heavy, jumping, and doing that often, as opposed to, and this goes for everybody, but as opposed to just like a zone 2 cardio thing.
Yeah.
Okay.
And also making sure if you're a middle-aged woman, you're not just blaming it on, if you're anxious, sad, you seek treatment to make sure your hormones are in a good shape, good place, and that you don't need that adjusted too. Yeah. Because that'll worsen that arthritic change.
And then trying weightlifting.
Yeah.
Trying
100%.
appropriately getting to where you're jumping, maybe for the first time, even if you're 45 or 50 or something like that.
It's going to be more important at that point. And then lastly, another cause, so I'm throwing out a lot here, but is insulin resistance. So that goes along with being obesity, but if you have insulin resistance, you're getting more. That means what insulin resistance is the cells aren't taking up, there's certain receptors on the cells that aren't functioning properly. So you can't bring the insulin binds to those cells and lets glucose, sugar, come into the cells.
The opposite of insulin sensitivity.
Right.
Yep.
So if you get more glucose roaming around in the bloodstream, then it'll deposit into the muscles or fat cells, and that can increase inflammation. So if it's in the muscle cells, you can get wasting of the muscle and deposition of fat cells, so then you lose that muscle mass, which we talked about last podcast. And then also, if you're getting more fat cells, you have adapokines, which will then increase inflammation. So just a whole host of things that can worsen arthritic change. It's not just age related. There's a whole factor that go in, but everyone's going to get it, so we can modify, and we're all going to get older, so we can't change that factor. But everything else we just spoke about, we can modify to slow down the rate of change of arthritic joints, but also to help improve it, so you're not painful.
So when you're talking about insulin too, this is when I'm the athlete who hasn't really done much. I'm insulin resistant, and why it feels like I'm moving through drying cement, or why the muscles tend to feel like they're on fire when you start working out. And a lot of that becomes really uncomfortable because you've sort of set this stage where it's just hard to get ramped up and get going. And it's really important for coaches to talk that through with their athletes, that in the beginning this is gonna feel a lot worse, even with a lot less. And the perseverance of this, and even just the knowledge of that,
100%.
is tremendous to be able to keep going.
And also not just jumping into something crazy, but go slow.
Yeah.
And warm up and things like that.
Now, so once I've been diagnosed, then what am I to expect? And I guess maybe give me a general, what am I to expect? What's a flare up?
Yeah.
Do I get that if I go too hard? Do I get that if I get sick? Like if I catch a cold, is there a better chance for me to have a flare up? And what needs to happen around that?
So when we have arthritic change, as I mentioned, with hormonal changes or insulin resistance, both of those things, if we have less estrogen, if you have more adapokines in the fat cells from insulin resistance, you're going to have, that will cause increased inflammation. So if you have a cold and your immune system is fighting off the cold, but the rest of your body wears down, you can have more inflammation.
So that's a flare-up.
Yeah, exactly. So yes, if you have more inflammation in your body, it's going to be more painful. Because inflammation, those cytokines, which is what inflammation is when you have increased interleukin 1, 6, TNF, all those things are released in the body when you have an inflammatory process going on, and that's going to bind to the nerve endings, and that's going to increase your pain sensitivity.
So exercise is pro-inflammatory?
Absolutely. Well, over too much exercise, absolutely.
Okay. When you get in and stimulate the muscle to actually do all of the things and you excite the system, is it going to make it feel worse?
Depends how conditioned you are.
Okay.
So if you're, it's because you're stressing that part of the system. So that stress will increase inflammation. And we always get scared of stress. We need stress in our body. That's how we respond to things, flight or flight wise, but also to break down muscle and build it back up. You need some kind of stress to the system, or like you mentioned with loading to build up bone.
That's why we're always racing to load the athletes so they adapt, come back bigger, stronger, faster.
Exactly.
Yeah. Okay.
So it's just, that's where an individualized approach is so important. Knowing your patient, taking a history, and it's not just a cookie cutter, everyone with back pain comes in and gets this treatment, because it may not be enough for some, or it may be too much for other people.
Yeah.
So you have to really have an individualized approach.
I'm glad you say that. I mean, that's a big deal. It's great to have the 20 athletes in one class, but even in 20 athletes in one class, there still needs to be that scale per person, right? And that's a big deal. So if you have your 20-year-old doing box jumps, and then you have a 60-year-old deconditioned exactly like you said, even if first day in they could do a box jump, it probably is not a good idea.
It's probably the best place to start.
Right. Can we do calf raises?
Yeah.
What do you feel like after 50 calf raises the next day as opposed to even 15 box jumps? Now let me ask you, once I'm there, once I've had my diagnosis, once I start fitness, and it does flare up, I'm assuming that you said since it's an inevitable thing, there are going to be little turns where it feels like I'm going downhill. Do I stop that day? Do I stop for a week? I
always have them gauge it based on the level of pain. If you can still function and tolerate it, the best thing is to keep moving.
Okay.
So
I'm not doing any more damage.
No.
Okay.
Not at all. I mean, this is part of the process. It's just flared up because of that inflammation and the nervous system getting sensitized with that and sending that pain signal.
Should I take an anti-inflammatory?
If you need to, you can, for sure. So I had mentioned in the past podcast that often with an acute injury, ibuprofen, naproxen aren't the best thing to take if it's soft tissue, but if it's inflammation from arthritis, that will help quiet it down.
Can you tell me why? What would be the difference of the soft tissue versus the...
Well, because we're just trying to decrease the inflammation within the joint.
Got it.
We're not if you take it for a strain of a ligament, that's going to decrease that healing, because we want some inflammation to come into that soft tissue to help that tear or strain heal.
Got it.
Versus in the joint, we're not trying to heal anything. We know you have arthritic change. We'll say it's part of that aging process. We know it's there. We know it's nothing bad.
This has to do with the blood flow that goes to a bone and a joint as versus a blood flow that goes into a ligament and a tendon, correct?
Yes and no, because if it's a bony fracture, I wouldn't want you to take the NSAID either, because I want that inflammation to help with that fracture heal. But just to decrease the inflammation in the joint, if we know it's not a fracture or a tear, it's just that arthritic joint that's flared up.
Yeah.
It's okay to take that anti-inflammatory, because we're just trying to decrease, we'll call it the edema or fluid that's built up from the inflammation.
And then from a coaching standpoint, again, you would scale.
Correct.
You would adjust, but you would keep moving as much as you could.
Would you?
Oh, for sure.
Yeah.
For sure, 100%. Yeah, exactly like you said. The moment you walk away from it, I think we do a little bit more psychological damage than anything.
100%.
And that's it's real important to maintain the routine. And I think that after a couple decades of fitness, that oftentimes becomes more important than exactly.
Well, then we go into those past topics we've had with you start to get fear avoidant,
that's
and
right.
it becomes more of a neurological problem than the joint.
Now, that being said, if I've trained really hard for decades, I mean, I've been in the gym for decades, never missing.
Right.
Am I going to make that worse?
So that's a good question.
Am I going to wear and tear?
So let's say you're a power lifter. You've been doing heavy deadlifts for years. Your max is, 500-600 pound deadlift. Over time, because age is creeping in, you may have to, if you keep flaring it up, because as I said, some of this is overuse mechanical stress. It's not just all age related. Mm-hmm. Some of it is just from too much load on those joints over time.
I'm a weightlifter. I squat 3 times a week. I also do cleans. I do snatches, all the same stuff. Okay.
So at some point, yes, you're going to have to curtail that and now maybe reset your goal. So your goal was to get as strong as possible. Now maybe it's be as strong as possible when you're 90 as you are right now. So you may have to curtail your goals of why you're doing this fitness training so you don't keep re-injuring. If you're starting to get enough arthritic change where you'll have flare-ups after flare-ups after flare-ups, obviously we got to back down somewhere. It doesn't mean don't do it. It just means modify it.
So this is good to talk about in terms of I didn't go and get a diagnostic, but I'm having those nagging, creeping up flare-ups, injuries, issues, insults, whatever it may be. I have that happen. Maybe it would be a good time to either talk to a coach or just modify the program.
Right.
And it's something like I just said, okay, cool. I'm a weightlifter. I front squat on Monday. I back squat on Wednesday. I front squat again heavy on Friday. Maybe it's time to start experimenting.
Right.
Maybe it's time to take one of those squat sessions out. Maybe it's time to exchange all of the anterior work 4 times the anterior, 6 times the anterior, and try to get more posterior work.
Yeah.
But that may be a good sign. Again, I'm not diagnosed, but it's a good sign that this may be time to experiment.
Yeah, and if it's a flare-up one time, I'm not saying you have to change your goals, but if it's repetitively, you're modifying it flares up, or you rest for a couple days and go back to those squats or deadlifts and it's flaring up again, maybe that's when you start to think, maybe if I just modify this. A lot of times you won't need to come see someone like me. You can talk to your coach or trainer and modify that so you can keep doing the thing you want to do, but just maybe lesser intensity or
so at the same time, we're talking about don't stop when it hurts, but also adjust when it hurts. It's not necessarily, again, to use squatting for an example, I don't just keep squatting and hope that it gets better. I may need to adjust, but I keep moving.
Because if you just keep squatting, well, as we've talked about, you're just going to maintain that inflammation there. It's like it's hard to see in the back or a joint, but if it's your thumb and it's red hot and swollen and you hit it with a hammer, well, you're not going to keep hitting it with a hammer. You're going to let it rest and settle down. So it's the same thing we have to do with our body, is let that inflammation subside. Maybe it is you take a ibuprofen to help it, or just ice it, or just rest. You can still move it, but just limiting what you're doing. Now, if it's 10 out of 10 pain when that happens, maybe then you back off. It doesn't mean you just lay in bed, but you're not doing the lifting. You're still walking or maybe doing stretching as you can tolerate. And that's maybe when you get evaluated to make sure nothing else is going on.
Yeah.
But people get surprised when I say, I can see it in their facial reaction. They may not say anything when I say, well, you have arthritis in your back. And I just see they're like, are you kidding me? That's all it is? I had 10 out of 10 pain. This is the worst pain I've ever had. And it's just some arthritis. And then I have to kind of educate them, as we've been talking about here, that it's not just arthritis, but they said it has to be a pinched nerve, it has to be nerve pain. Well, it is nerve pain because that's what sends the pain signal, but it's not what you're thinking, like a pinched nerve being compressed or anything like that.
Is that novelty? Is that the first time I've had this, that not all of a sudden is it new, but also the catastrophizing of like, this is my
Well, if you've never had pain like that and it could be real bad, your body freaks out. You don't know what's going on. This is a surprise to you. It's something so new. Yes, versus someone that's dealt with this a couple times in their life or had injuries before in other areas, they're probably not going to rate it 10 out of 10 pain. But
I have to imagine that we've talked about this a lot in a lot of the patients that you've sent me, the athletes, that they always comment about how much you actually talk to them and how rare that is. And I think that's awesome. But I think that, would you also attribute that knowledge and you telling them what's happening, that takes the pain down without even having to do anything other than that?
Just that reassurance that it's nothing horrible and that the outlook is good. You're going to be getting back to doing the things you enjoy. 100%. That just changes their demeanor. Like I said, when I say it's just arthritis and they just go almost starting to get depressed, like, are you kidding me? Am I that wimpy that it's just arthritis? And I reassure them, no, this is normal. Of course it's going to be painful, but it's also going to get better. And that absolutely immediately improves them when we haven't done anything yet. So the mind is a powerful thing.
Yeah, we've talked about that in many podcasts, to start the fear of it, but then to counteract that fear, and then you're going to tell them something.
And to have that hope.
Yeah.
The worst thing you can do is, if it is arthritis, not show them the pictures and explain what arthritis is. If you have an X-ray or MRI or CT scan, and just read it off a list, tell them you have arthritic change. It's normal. Everyone gets it. Stop doing what hurts and come see me in 2 months. I mean, they have no hope. They think this is just a lifelong thing, and they're screwed because they have arthritis in their back, where that is not true.
That's a death
You don't have to have pain. We all have arthritis, everyone listening is going to get arthritis, but we're not all going to have back pain forever. So obviously, just because you have that arthritis, osteoarthritis we're talking about, doesn't mean you have to have constant pain. There's ways to modify it. And we've just talked about it, fitness and exercise, which is a huge way to counteract that.
So when they come to you, they're deconditioned. We talked about that deconditioned. We're not talking about necessarily the lifter who truly has 20 years of wear and tear. That may need to slightly modify. They're gonna slightly modify. They're not. If they've been in it for 20 years, you're not gonna see somebody who's gonna quit.
Right.
So they're gonna take all they can
to get back,
to modify as necessary. We understand that, but it is nice to understand what you're going to deal with, that when you're 30 years into the fitness game, that it may be slightly alter the program, but the program still maintains. That's a big deal. And I think it's good to hear that. But I come to you completely deconditioned. I've never done anything. You're going to actually tell me to go do the things.
Yeah, let's say I'll change that initial case. Instead of a 50-year-old man, it's a 50-year-old female, little overweight, sedentary. That is going to, we have a whole lot of things we can work on there. One, it's going to be explaining that this is a normal process. It's going to happen as we get older. We get these arthritic changes. Two, you're menopausal. What do your hormones look like? Are you in a good place with your estrogen, testosterone, progesterone? Are those in the right spot where they should be? Because as we said, that can affect how you one, the inflammation, one, how that joint degenerates, and two, also, if you have low hormone levels, that's going to increase inflammation in your body. So make sure that's good. If you're a little overweight, well, how do we work on that? Is look at your nutrition and your movement patterns. Do we need to fix that? Because a lot of what we said causes pain is inflammation. A lot of what we put in our body causes inflammation. So if you're eating, Chick-fil-A, which everyone thinks is healthy fast food, and a Diet Coke when you go, and then you also get a little, whatever they give for dessert there, that's going to cause a lot of inflammation.
That was my next question. Are there those outside of the gym, outside of my movement things like nutrition that I really need to pay special attention to, that we know irritates the system even more?
Absolutely.
And you're saying, from what I gather, it's processed food primarily, or is it sugar, or is it both?
It's sugar is a huge one. We touched on that with, if you're overweight and insulin resistance, that's going to increase sugar. So if you're putting if you're having chocolate cake every night for dinner and you're a little insulin resistant, then your body can't process that glucose, so it's going to stay in your bloodstream, increase inflammation. That's going to worsen pain.
Okay.
It's all going to worsen your muscles and increase your fat cells. So definitely what we put in is a huge component in this, in having pain from arthritic change. You want to eat as clean as possible. And what does that mean? Fruits, vegetables, lean meats, not processed, not packaged. People even, chicken cutlets that you get that you think is good, how processed is that skinless, boneless chicken cutlet you're eating? You want to make sure where you're getting that from. So there's a lot of things to think about when you're eating.
Is this a circumstance where it's like elimination provocation? So it's like, oh man, this, I feel like it's a flare up. You look at your diet, I do XYZ every day. Why don't I just take out X for a couple of weeks and see what happens?
Yeah,
what would be something that I would take out? Is there a primary
So the number one
offender?
thing is what I start with when someone I know has a poor nutrition and very overweight. I said, just don't have anything with added sugar. That's where I start with. So if it's a drink, don't be drinking the sweet tea, have the unsweet tea or water. So you want to stay hydrated, so you have to drink stuff, but eliminate that added sugar.
Is that primarily because of the insulin resistance, or is that primarily because of just the sugar on its own without even being
the insulin resistance? Because that's what's going to not allow you, you're going to overload the system. So insulin resistance it starts young. You may look completely fit as an 18-year-old, but that's when insulin resistance starts. So you may be
metabolically obese.
Exactly. So just because you're not overweight and you're active, but if you're eating junk food all day, you're starting to become insulin resistant, and it's affecting your body system.
This is syndrome X starting to kind of develop all of the different things, but one of the pathways the symptom could be arthritis.
Yes.
I could run into that.
Yeah.
Okay.
So that's the thing I start with is you look at breads. Why do we need sugar in bread? Everything has added sugar in it. All the processed stuff, just don't use it. So I just try to teach people, that's a simple thing to look at. A lot of people don't understand all the things on the labels,
Sure.
but they can see under carbs, sugar or added sugar, and you don't want added sugar.
In this respect, maybe the fewer labels or the fewer things on the label might be a better idea.
If you go to Paris, the bread has 4 ingredients in it. That's what bread should have. You go to Food City down the street, it has 35 ingredients. Like, what are we doing?
And that kind of bodes for staying on the perimeter of the store like we've heard so much of. Okay. Now, we said sort of what not to do. Like, what could I eliminate? Again, we run into a diagnosis. We're either working out, we adjust the workout. We're not necessarily working out, so we start training with a professional who can actually make me feel better.
Right.
We talked about eliminating maybe sugar and the heavily processed foods. Okay, great. Is there something that I could add in besides the workout? Is it just more sleep, better sleep, or is it I need more electrolytes, joint salts? Is it something like that?
Yeah, and there's one supplements you can take. Glucosamine is a big buzzword you hear a lot of people take. One, if we're with adding in with supplements, I don't even go there because that may give you a little bit of an edge. Maybe do 1 to 2% of the fix. Where if you're still eating that fast food and that garbage, don't even worry about the supplements. Let's eliminate the bad. So I focus on more eliminating. But if it's someone that's sleeping well, eating very clean, good, healthy, natural foods, and starting to move and exercise, then we talk about, you want to get enough, as we talked about last podcast, enough protein in to start to build up that muscle to complement the training.
So this is like the extra edge for somebody who's doing all of the things already. Right. Okay. Is it when it becomes when we age, it becomes more important to get protein as we age?
Yeah.
More protein as we age. Is that the case also? If I'm diagnosed with any sort of an osteo or a rheumatoid, that more protein becomes more profound, or does that not really take into effect?
Yeah, it definitely takes into effect. It's more because we're trying to build up that muscle around there. So we want to increase that stability around that spine. So as you strengthen those muscles, that almost causes that traction that we talked about. By the muscles taking pressure off those joints, you're going to have less when you stand up and load the back or the hip joint. You have arthritic change. If the capsule around those joints, the ligaments and the muscles on top of that are stronger, that's going to take pressure off the joint itself or give you a little bit of that traction, unloading that joint. So that's where protein will definitely come in, by maximizing your benefits you're getting in the gym, or what you're putting in the gym, to maximize those benefits by having enough protein to fuel those muscle cells.
Do you see, talking particularly about athletes, do you see one athletic domain that comes in more than another? For instance, maybe you see more runners, so that would be a poor question, but is it I run a lot, therefore, and it's specifically this person, or I lift a lot, therefore? Is there somebody like that comes in that you could point to and be like, they are a little more susceptible, or not?
Absolutely. So as we talked about initially, it's part of that arthritic progression. What causes it to become more symptomatic is mechanical, and we mentioned it, pitchers throwing with their shoulder, but absolutely, if you do one movement repetitively, that's going to wear down that joint. So runners, often it'll be their hips or sometimes their low back, if that's all you're doing and not cross training. So it doesn't mean don't run, it means complement it so you can keep running.
Right.
But absolutely, there's definitely subsets. The most common thing I see is the sedentary person getting arthritis, and that is counterintuitive to what a lot of people think. It's an overuse injury, and it can be an overuse injury, as we just mentioned, if you're pitching all the time or running all the time on certain joints. But being sedentary, I'd much rather deal with that than the person who's sedentary, because then you're getting increased inflammation, you're getting insulin resistance, you're losing your muscle mass, and so that's putting more pressure on that joint and wearing away the cartilage in there. So it's going to become more of an issue and harder to treat. Versus, I'd much rather see the runner come in with hip pain, because we can just alter their training some.
So when you see stuff like that, you're thinking like what I'm thinking, like it looks like it could just be inappropriately programmed.
Yeah.
It looks like this athlete could, again, if we're running 5 days a week, we're putting in 15 miles each time. Well, what if we even pulled back a little bit on the mileage, added in another strength day, another 2 strength days? Maybe my runs get a lot better.
No doubt it will. And I see that all the time. Better. They come back, whether it's people that like to bike ride or run, they often don't strength train as much, and then they add in that strength training piece, and a year later they're realizing I'm way better off than I was by just adding this in, and I don't hurt.
So if I could review, the arthritis is inevitable. We're going to have some sort of arthritis, but we may not experience it necessarily as a pain. Is that correct?
Most people won't.
Okay.
We're all going to get arthritis in our joints, but if you're doing the things we talked about today, maximizing sleep, nutrition, movement, most people won't know they have arthritis.
Okay, and then so that sounds a lot like, if I could continue to review, number 2 would be that I should start now if I haven't started, if I'm 20, but also if I'm 60.
Right.
Okay.
It's prevention. So as I said, that insulin resistance starts at an early age, and as that's starting in the background, if you're not building up that muscle, supporting those joints, you're just setting yourself up for, universally, what I see my patients, and they're into me because they have pain, they say, well, just enjoy your youth because growing old sucks. Well, I don't say it, but I want to say, well, it doesn't have to. We can make it better now, but also, what did you do in your life to train your body to get to being 70 so it doesn't suck?
Okay, so that takes me down another road. So the number 3 is, if I've waited longer, it's going to take me longer to get back to a comfortable spot, but I can still get there.
Yeah, absolutely. You may not be, it may be to the point where you're not going to be pain-free, but I always say, let's make this tolerable so you can do everything at 70 that you want to do.
And one thing you said that was really cool that I loved, and I want to review this, and just to hit it, is we can expect change. And change, I think that's maybe more the terrifying thing, that when patients come to you, that they've had a change, and maybe it is a little uncomfortable, but it's because it's change that makes it tremendously uncomfortable. And you do a really good job of presenting to them like, hey, there's still life. You may need to change some of your behavior, even if that behavior's good. Like, you've been exercising 5 days a week. Hey man, that's great, keep doing that, but just alter it ever so slightly.
Yeah.
Okay.
What if, so when we go back to that kind of prevention and things, what are some things as a coach that you would have people do?
Dusty and I have talked a lot about that and some of the exercise specific things. I think one of the first things is exactly what you've talked about, and talk them through what's going to happen. Today's going to be a little bit uncomfortable, but we're not going to go past a marginal increase in discomfort. So if you're at a 5, whatever you call a 5, maybe it's at a 6 as we're working out, and it's going to kick down. We're going to do what's called tolerance testing. So tolerance testing is going to look like, I'm going to, based on whatever you're telling me, whatever you're giving me, whatever the diagnostic is that comes through, I'm going to build a program based off of that, along with 20 years of experience, and then I'm going to test it on you. You're going to go home hopefully feeling like you didn't do much. And then you're going to text me later that night or the next day, and you're going to tell me how you feel. Mm-hmm. Now, if I've done a good job, and hopefully 20 years into this, I can kind of gauge what's going on, is that I kind of sold it short. I never want to go overboard, but you're going to text me, you're going to tell me, I feel great, cool, let's do it again. And we're going to constantly tolerance test for anywhere from 2 weeks up to months, depending on, again, how deconditioned the athlete is. Tolerance testing, and I can get into all of the exercises, but I'm not a award-winning fan of, it has to be a bird dog, or it has to be a glute bridge. I want to do a movement that gets you moving, that doesn't feel threatening. If I can hand you a heavy barbell and you're great with that, okay. But if you get on the ground, which seems like the easiest thing in the world, but you've had trouble getting up again, you'll see the athlete sweat when you ask them that. You'll see, and they'll like, oh, how do I get up in front of this person? I mean, that's a horrible place to be. If you're, and this is with everybody, but if you're a 50-year-old man who's worked with his hands his entire life, who's done things for his family his entire life, and then stuff started to set in, and then you're like, hey man, can you lift this overhead? And he's like, no, I can't lift overhead. So it's not about asking those things that are gonna psychologically create an issue. It's about finding a little bit of movement that works really well, and then building on top of that. Like I mentioned, I'm not gonna have you first time in, you're 60 years old, hey, let's jump on a box, even if you could, even if I thought you could. It's never gonna be that. It's gonna be, can we do some calf raises? And he's gonna be like, I didn't feel like I did anything. Good. Yeah. Good. Like, we're not trying to set a record today. I want to see how any of these movements that I put together based on talking to you feel the next day, and then the next day after that. Then after we do that, we're going to set up a program that's going to be around weightlifting. Now, to load an athlete though, if I'm standing here and I don't have an external load, I'm not holding a dumbbell or a barbell, okay. But if I just go to one leg, that's loading the athlete. You're loaded when you go to just when it's the unilateral piece. So I may stick with just unilateral movement before I ever compress the joint. I may make sure that you're able to do step-ups unilaterally for months before we ever do that, if that's what it looks like. But on the reverse side of that is I may take an athlete who just does really, really good, profoundly good the first 2 weeks. Here's the barbell. It is so individualized based on the previous day in the previous week. Just like you said, it's not a template. Whatever you're giving me today is how I've managed this program. And then when you walk in, that next day is off of the previous day.
And it's building and stacking those.
It is, and that's real important. But then, and I know you know these things, but for our listeners, it's here's what I had in mind. Well, that's not going to work today.
Right.
And that's okay. And for me personally, that was a great lesson to learn in my own program, because I'm sure you've done this too. Here's what I'm going to do today, and I'm going to do it at all costs. That will only get you so far. And I would never do that with an athlete, but I did it to myself for years. And after the longest time of just tolerating injury, what would happen if I actually treated myself like I was
like a patient?
Yeah, exactly right. And then all of a sudden, I feel great.
Yeah. Well, I love that, because it's so, as we've said a couple times now, just individualized. It's not, you're assessing that patient and building that program off where they are and where they want to go. And also just not sticking with what you did on day one. Each day you're reassessing, or maybe it's months in, you're still reassessing and adapting and adjusting, which
all the time
is so unique, unfortunately.
It is, but after you start to see where that takes you, it's the difference of taking the stairs or the elevator.
Yeah.
You know, 2 sessions in and we're so much further along than a template.
Yeah.
And it's profound.
That's awesome.
Well, hey, thank you, sir.
Yeah,
I appreciate the time.
Hopefully Dusty will be back next week.
That's right. Thank you for watching. Join us for much more where that came from. And when you get a chance, follow us on Instagram and YouTube at Back in Action Podcast.